Hello and welcome to today's webinar Wednesday, brought to you by the North Dakota Brain Injury Network. My name is Sarah Ring. I am a speech language pathologist at Sanford Health in Fargo, North Dakota, and I'm excited to bring you part two of a three-part series on the Rancho Los Amigos scale of cognitive recovery. I am going to share my screen so we can dive right into this content. I'm excited to talk about the middle phase of recovery. That's not the one I want. Let's start here. All right. And so let's review today's objectives. My goal is, one, I hope that participants are able to describe three practical uses for the Rancho Los Amigos scale of cognitive recovery. We're going to spend some time talking about the scale in general, as well as practical uses for your team if you are a healthcare provider. Second objective, participants will define behavioral characteristics of individuals at Rancho level 4 through 6. We're going to talk about those characteristics. I'm going to show you some video clips of those characteristics to help you define the unique characteristics of this middle phase of recovery. And lastly, I hope that participants are able to become familiar with strategies that can be very effective in management of neurobehavioral consequences for individuals with traumatic brain injury in the middle phase of recovery. I want to clarify that use of this scale is most appropriate for individuals following mild, moderate to severe traumatic brain injury. The Rancho scale is not appropriate for individuals who have sustained acquired type brain injuries. So individuals who experience stroke, brain tumor, brain infection, hypoxic brain injuries are not the appropriate population for which this scale was designed. We are going to use the Center for Disease Control and Prevention definition of traumatic brain injury as a working definition for the population for which the scale was created. Traumatic brain injury, or TBI, is defined as a blow or jolt to the head or a penetrating head injury that disrupts the function of the brain. Of course, not all blows or jolts to the head result in a TBI, and the severity of an injury can range from mild to severe in nature. A TBI can result in short or long-term problems with independent functioning. It is the current practice that brain injuries are classified by either mild, moderate, or severe definitions. We're going to briefly review these different severity levels as they often coincide, I would say consistently coincide to various Rancho levels that we are learning about in this webinar. So individuals who are diagnosed with a mild traumatic brain injury often present with neuroimaging that does not reveal evidence of brain injury. That does not mean that brain injury did not occur. There is just no evidence on neuroimaging. Individuals may experience loss of consciousness from up to 30 minutes, but you do not have to experience loss of consciousness to be diagnosed with a mild traumatic brain injury. Individuals with mild injuries do experience an alteration of consciousness even from a brief moment to up to 24 hours. And individuals with mild injuries may or may not experience post-traumatic amnesia or that difficulty learning new information following time of injury. The Glasgow Coma Scale, or the GCS, is used in emergency departments and by EMT professionals to briefly evaluate function at the time of injury or admission. And the scale from 0 to 15 offers some predictive aspects. Individuals with mild injuries are rated with a GCS of 13 to 15. Now, I do need to clarify that even though injuries may be classified as mild in severity, severity does not equate to function. So if you have a mild traumatic brain injury, it doesn't mean that you only have mild consequences from the TBI. We all know individuals who have been diagnosed with mild traumatic brain injury who have significant consequences and persistent symptoms after mild injuries. Moderate injuries often do reveal themselves on neuroimaging source. So CT or MRI images often indicate evidence of bleeding, contusion, fracture, and the like, which assists with diagnosing level of severity. Individuals with moderate injuries experience loss of consciousness greater than 30 minutes, but less than 24 hours. Alterations of consciousness are consistently greater than 24 hours in severity. And post-traumatic amnesia ranges from greater than 1 to less than 7 days in duration. Those initial GCS scores range from 9 to 12 for individuals diagnosed with moderate TBI. And finally, severe TBI, certainly evidence on neuroimaging is observable. Individuals experience loss of consciousness greater than 24 hours, PTA greater than 7 days, and are initially given GCS scores that range from 3 to 8. A variety of factors determine prognosis following TBI. Most significantly, according to research, is information specific to location of injury and severity of injury. Certainly, age at injury is a critical factor, particularly as we discuss brain injury for pediatric and adolescent populations. Understanding that the earlier the injury is not better, leads to poor outcomes for those kiddos and adolescents whose brain development was interrupted, and with resulting consequences on skills not yet acquired. There are factors that an individual brings to their traumatic brain injury that also influences their prognosis after injury. So factors related to pre-morbid intelligence, psychosocial factors, certainly any pre-existing conditions, and history of previous brain injury all influence one's prognosis following TBI. It was those factors that, in addition to the the launching of this concept called brain injury rehabilitation in the 70s and 80s that launched this particular facility at the Rancho Los Amigos National Rehabilitation Center to consider development of a tool to assist their team in planning something that had some prognostic benefits, and thus the Rancho Los Amigos scale of cognitive recovery was developed in 1972. Some mild revisions were done in 1974. And again, the scale was developed based on this assumption that observing an individual's type, nature, and quality of observable behavior could be used to estimate the cognitive level at which a patient was functioning, and that there was some predictability in the across the duration of recovery in which individuals would display particular behaviors. And so the scale originally had 8 levels. And in 1997, levels 9 and 10 were added to better reflect the highest levels of recovery. Each level is presented as a behavioral description in a narrative form. And this allows the rater to best describe patients' present behaviors. What do they observe? How do they observe the patient behaving? And it should be stated that researchers have found that inter-rater reliability using this scale is very high. And so that's just one of several factors that I think are make use of this tool practical. And I encourage your team, if you do not presently use this scale, to strongly consider this for a variety of reasons. Not only is inter-rater reliability high, but use of the scale in general offers your team the ability to use common language. Whether you are a speech-language pathologist or a physical therapist, a nurse, a physician, a social worker, cognition is everybody's business. And so the way that an individual behaves and interacts with others has everything to do with the work that you do with them. And so understanding what is to be expected at various levels of recovery following brain injury allows everyone to speak the same language during those staff meetings, in documentation. And this language helps guide rehabilitation plans. It allows your team to predict outcomes as well as evaluate recovery after TBI. I would also state that the use of this scale is very, very helpful when educating family throughout the course of recovery. This is a difficult time for family members and friends, and the language used in this scale is easy to understand, and use of the scale is encouraged by family members as well. This slide simply lists the 10 levels along with the predicted level of assistance that individuals require at each of the levels. This, again, is a 3-part series. The first session focused on understanding levels 1, 2, and 3, or the early phase of recovery. Today's session focuses on the middle phase of recovery, or Rancho's level 4, 5, and 6. And our final session in the webinar series will discuss the higher levels of 7, 8, 9, and 10. So today we're going to talk about Rancho level 4, or confused agitated, Rancho level 5, confused non-agitated, and Rancho level 6, confused appropriate. So individuals in this middle phase of recovery have emerged from coma and are experiencing a heightened state of arousal with difficulty regulating behavior. Individuals are confused and unable to pay attention or remember information from minute to minute. General goals for the team are as follows. We need to be concerned about safety. Individuals are confused and agitated and are often acting out and place themselves at increased risk for repeat injury or other injuries as a result. So, decreasing confusion and agitation in a variety of ways that we will discuss during today's webinar are at the forefront of our goals for this patient population. Our goals are to certainly consider one's ability to pay attention to a therapeutic activity or during a meal or when taking vital signs. How well can an individual pay attention to tasks? Our goal is to then further increase other higher level cognitive functions as able by implementing structure and repetition. And we're going to talk more about how to do that in this webinar. And then finally, education. Certainly the focus on education is family. We can educate by modeling behavior, providing specific strategies of how to manage behavior and anticipate behavior. And hopefully the content in this webinar can help you add to your toolbox as you work to educate family. General principles of management for individuals in this middle phase of recovery. Certainly, every person with brain injury responds differently. Remember, if you've seen one brain injury, you've seen one brain injury. And so it's difficult to give specific suggestions on how to handle behavior. But in general, for this phase of recovery, we can work toward meeting those goals of decreasing confusion and agitation by doing things like modifying the environment in which that person is sleeping, eating, and having therapy. We can consider behavior modifications. We can provide structure and routine with a daily schedule and with staff that decrease confusion for an individual who struggles to remember information from day to day. Using simple language, giving an individual information. Individuals are confused and are unable to remember new information. It is important that we give them information about where they are and why they're there, rather than quizzing individuals at this phase of recovery. And again, supporting cognition, things like attention and memory and orientation to support cognition and decrease confusion. All right. Rancho level 4, or confused agitated, is a difficult phase for family and friends. As the individual's brain is waking up, we find that individuals have difficulty with managing their behavior. Individuals exhibit alert and heightened state of activity, and often that activity is non-purposeful. Individuals may cry or yell out or scream. They may be physically moving their arms, be unable to sit still, demonstrating observable behaviors of restlessness and or agitation. Individuals may hit out, try to remove tubes, may try to get out of their bed. They're confused, and they're certainly not doing these behaviors on purpose. Individuals are unable to demonstrate awareness or any other types of high-level thinking at this point. I'm going to, stop sharing this screen. And I am going to attempt to show you a visual example of an individual functioning at, actually there's two individuals functioning at Rancho level 4. So I challenge you to watch for those observable behaviors that I mentioned and consider how supporting these individuals can be more challenging. Now, let me see if I can share this screen. Here we go. All right, so these clips are taken from education information produced by Craig Hospital in Colorado. And so I hope you find this helpful. I will play just about 2 minutes of this clip, and then we'll circle back to our PowerPoint. Okay, stop sharing that. So we just had one individual there. I forgot which one we were on. Okay, let's head back to our other slideshow. Get back to where we were. Current slide, here we go. Okay, so I think that it was pretty clear the observable behaviors, the restlessness, the confusion, the overstimulation over time. And we know that it takes an injured brain. An injured brain has to work harder to make sense of the noise and the light and even tactile and smells and all the senses, all of that input that we take for granted for those of us who have not had a brain injury, particularly in this phase of recovery, all of that input can become very overstimulating, and it really manifests itself into these behaviors that are exhibited as restlessness, agitation, and further confusion. And so ensuring that we can do what we can to manage our environment for the individual and modify the way that we interact with the person with TBI, the best outcomes can be predicted. It's unrealistic to think that we can do away with all negative behaviors exhibited by someone at this level, but the goal would be to minimize inappropriate behaviors. So what can we do? We can ensure that an individual is offered a calm, orderly, structured environment, one that is free from bright lights and loud noises. Certainly limiting visitors would be important at this time. Perhaps your facility, like mine, has what we consider low stim guidelines. And so someone at this particular level of recovery, those level 4, 5, and 6, would certainly be placed at what we call a red stim level, where there's no TV, there's no phone, limited visitors, and we do therapy in the room for these individuals to just minimize that sensory input. When an individual is being spoken to, it's important that we use short, simple, and concrete spoken information, that we are giving information, not quizzing individuals to give us that information. They are unable to remember information from day to day, and therefore need to be verbally provided information, as well as other modes of communicating information. We implement orientation boards at our facility. So boards in which the day, date, month, year, place, reason for hospitalization can all be hung in one's room, and that information can be reviewed with the patient frequently when questions regarding time, place, reason for hospitalization are perhaps initiated by the patient. During the instances when behaviors are exhibited, redirection is often an effective mode of reducing exacerbation of behaviors. So for example, if I'm seeing a patient in their room for therapy and they become agitated or very restless, some patients may find it beneficial if to change of scenery. And yes, I'm bringing them out into the hallway where there's more stimulation, but sometimes just simply wheeling them around the rehabilitation unit and holding our conversation and giving information while moving can be enough of a distraction and enough of a redirection that the patient's behaviors de-escalate, and we're able to work for a longer period of time. Certainly providing offering choices and providing assistance with tasks to prevent, again, restlessness and agitation. We want to encourage independence, as is an individual is safely able to do so. However, we need to make sure that there's a balance, and that if an individual becomes upset or agitated, that we we stop the activity, we modify the activity, we add more assistance during the activity. Now, certainly an individual at Rancho level 4 is not trying to be obnoxious and not trying to act out. Do not take information or comments personally. And certainly do not attempt to argue with the patient. They are unable to exhibit those higher level reasoning skills, and it is in your best bet to remain calm and remain flexible with the goal of redirecting behavior and modifying the environment for individuals at Rancho level 4. Rancho level 5. So we know brains are recovering, and progression through these levels is expected. The rate at which one does that is unpredictable, and the rate at which one achieves highest level of functioning is unpredictable. At Rancho level 5, or confused, non-agitated, individuals continue to require maximal assistance, but individuals begin to appear more alert and more able to follow simple commands. Individuals may be able to concentrate for shorter periods of time, but still need redirection. Individuals are highly distractible, and so determination for therapy in the room versus therapy in the department, those conversations start to be had about Rancho level 5. New learning is still difficult. Individuals often still are exhibiting severe memory impairment and post-traumatic amnesia. So ongoing support with new learning and memory as well as orientation is recommended. Individuals may continue to exhibit confusion and as well as impaired awareness and insight into why they need to be in the hospital. I am going to stop sharing and again show you a clip of an individual at Rancho level 5. And so again, I challenge you to compare the visual and written descriptors that I offered for a Rancho level 4 patient now to this Rancho level 5 patient. Okay. I hope I was sharing that. I have a feeling that maybe that one didn't get shared. I'm going to go back to here for a minute. And let's go back to our PowerPoint. Appreciate your flexibility as we bounce between. I hope that you found that visual example and observable behaviors to make sense with a progression, a recovery after brain injury. You saw that individual be able to hold a more appropriate conversation despite confusion when we versus the individual at Rancho level 4. How can we support individuals at Rancho level 5? We can continue to give information and repeat information in order to reduce confusion and support cognition. We're trying to assist individuals to improve in their memory and orientation skills. And so by giving information and repeating that information, that's an effective option. Also encouraging the use of orientation and memory aids. I talked to you already about the orientation board. I encourage ongoing use of that for individuals across all levels of recovery. But at this level, some teams consider further support in regard to memory and new learning. Our facility considers implementation of a memory log, or some people call it a daily planner, or what have you, but we're talking about an external memory compensation tool in which the patient can be supported to write down events that happen within their day. This then serves as a memory log or a diary in which they're able to look back and again, support their memory. Spoken language and directions or instructions should continue to be simple and short, as well as concrete in nature. We can offer choices when appropriate, and individuals may require assistance with organization and sequencing of those basic tasks. So my OT colleagues and ADLs specifically may see difficulty with that task and be able to report that back to the rest of us who don't necessarily, like me, I don't, as a speech language pathologist, I'm not in on those basic care activities, but I can benefit from an OT providing language that's consistent with patients at Rancho level 5. Routine and consistency is very, very critical at this phase of recovery. We know that repetition supports memory, and so the more consistent a routine can be, the more consistent staff can be, the better for individuals at this phase of recovery. Individuals may benefit from ongoing modifications or limitations to their environment, including number of visitors. And I should mention perhaps at this point that individuals' level of recovery may function multiple times within the span of one therapeutic day. So in theory, one may wake up after a restful night of sleep, and his nurse may identify behaviors that are consistent with Rancho level 5. However, as the day progresses and there have been multiple opportunities in which this client has been exposed to stimulation, perhaps pain has increased as the day's gone on, perhaps rest breaks or naps weren't taken for one reason or the next. An individual very well may begin to exhibit behaviors consistent with Rancho level 4. And so being aware of that, and we'll talk at the end of this webinar about other things to consider when you are documenting and communicating the level at which you think a patient is performing. Finally, for this webinar, we are going to review Rancho level 6 or confused appropriate. At this stage, a person's behavior is more functional. The patient likely will be able to remember events from day to day, but still may remain in post-traumatic amnesia. So we'll continue to rely heavily on external supports for memory. Individuals are able to follow simple commands, but may struggle with complex directions and sequences. Behavior is goal directed, but individuals may require cueing from therapists and staff. If staff and routine has been consistent, patients may exhibit some vague recognition of staff, but overall memory for new information is difficult. Individuals do lack judgment and ability to problem solve at this level of recovery. Again, safety remains a concern because awareness and insight remains impaired. An individual may consistently ask, when can I go home so I can drive my car? When can I go home so I can get back on my motorcycle? So this is where our education efforts should more heavily lean into the patient being able to begin to comprehend some of that information. I'm going to stop sharing this screen and again share one more example of an individual at, let's see, I'm going to do this. I'm sorry. Let's do this. I'm going to share my client at Rancho level 6. And again, compare with the visual that I offered you for individual at level 4 and level 5. Here is your client at Rancho level 6. So I'll stop sharing there. So again, I hope you found that, hope you found that visual helpful. Let's do this. Get back to our PowerPoint for our last few slides. Okay. So clearly that individual was able to engage in a reciprocal conversation. He was able to demonstrate recall of the benefit of his daily planner, but exhibited impaired judgment and problem solving when posed with a functional scenario. So how can we support individuals at Rancho level 6? We can encourage independence. Obviously, we are there for support, but certainly independence is the goal. Individuals at Rancho level 6 are often able to tolerate therapy off the unit. Again, daily routine therapy schedule is best tolerated when it's consistent and follows a routine that is not only verbally stated to the patient, but also provided in printed form for them to refer to as an external compensation tool. At this point, giving information that still is clear and simple as far as information and instructions, ongoing use of memory aids and other compensation tools are strongly encouraged. The orientation board, memory aids, watches. Individuals can tolerate, again, therapy off the unit, though overall use of electronics may still be limited at this point. So there we are. The middle phase of recovery, Rancho levels 4, 5, and 6. I hope that the information we reviewed regarding the specific descriptions of these 3 levels offers you another glimpse into the benefit of user-friendly common language that can facilitate that communication among your team and help guide planning for individuals after brain injury. The tool does allow teams to predict outcomes and evaluate recovery after TBI. I was thinking that for survivors who are on this webinar today, I challenge you to take a look at the 10 levels and see where you would level yourself today. And do you vary from level to level depending on various factors? Perhaps that can help you structure your days. What strategies and tools can help you maintain the highest level of functioning stated on this scale as possible? Now, not every individual after brain injury starts at level 1 and ends at level 10. Some individuals never get past level 4. We talked last week about some individuals don't get past level 1. And sometimes so we're unable to predict highest level of recovery. And so the goal would be to maximize the highest level of recovery as possible using the tools and strategies that you've learned across your course of recovery to maximize functioning. As we consider how to level a patient, how to give the patient a level, how do we do that? What factors do we consider? Well, we consider those observable behaviors, certainly, but there are several factors that can influence one's level of functioning. I've listed some. This is certainly not an all-inclusive list right here of some factors that can influence the level of recovery. I mentioned earlier the example of someone who gets a good night's sleep and wakes up and potentially is leveled at a Rancho level 5 by his nurse that morning. However, by the time he potentially sees me at 3 p.m., and he's had multiple therapeutic opportunities throughout the day. He perhaps has increased pain as the day has gone on. Perhaps he wasn't offered rest breaks or naps during his day. I might exhibit or I might document that he's exhibiting behaviors consistent with Rancho level 4. And then I need to make sure in my documentation that I explain why that those behaviors are likely being displayed. And again, likely modify my treatment plan for that session as a result. So being sure to consider these factors as you're leveling someone, and then be able to explain that either verbally in a staff meeting. Well, I saw so and so at Rancho level 5. Well, I can understand that, but it's important for us to understand as a team that when he doesn't get his rest breaks or we aren't managing pain, that his level of functioning decreases. And here we are trying to problem solve how to manage behavior again. So can we as a team more consistently manage pain and sleep routine and some of these other factors? And so here we are in ongoing awe of our fabulous brain that has everything to do with everything we do. And we are able to use a scale like the Rancho Los Amigos scale because of neuroplasticity. We know that the brain is able to rewire itself. And we know that if you are a therapist, that what you do is changing brain. We know that supporting individuals at each level of recovery offers opportunities for that brain to rewire itself across the course of recovery. And thus, we are at Rancho level 6. And because of neuroplasticity, we're going to, in the next final session, talk about Rancho levels 7, 8, 9, and 10. So thank you for your time today. I look forward to you hopefully attending the final series, and I wish you the best of the rest of your day. I will stop sharing and sign off. Thank you so much.